Dr. Larose completed his medical degree in 2014 at Laval University in Quebec City. He then completed a certification in internal medicine before pursuing training in hematology, also at Laval. He also completed a medical oncology specialty. He is currently at Princess Margaret in a clinical and research fellowship in myeloma and also in lymphoma. I've met Dr. Larose on a number of occasions, either as a patient or as a caregiver for another patient. He's very good at explaining things in ways which patients can easily understand. And he is also a most kind gentleman.
Okay, so once again, I'm very happy to join you for this festive presentation, and very happy to see everyone so joyful about the holidays, because one of the main objective, of course, when we treat multiple myeloma is for patients to enjoy life as long as they can. So being able to see you smile and so festive today is very something I was looking forward to. So the purpose of the presentation today will be focusing on the new treatment approaches in multiple myeloma. So mainly, as the presentation said, mainly about immune therapy, which is a very good thing. And I hope I can convince you that there is a lot of hope for anyone with multiple myeloma now, with so many new options coming on the way. So before getting to the core of my presentation, I just want to remind a little bit of what's already in place, like the older therapy. Some of them actually are not even 10 years old. So a lot of the really standard of care drugs now are kind of new. So really the field is evolving at a very, very fast pace, but we already have plenty of drugs that we can use. Many of you who have been treated for multiple myeloma should probably know about the standard chemotherapy that we still use for multiple myeloma, like cyclophosphamide is one of the example. If you have received Cybordy, then it's the Cy part of it. So we still use commonly cyclophosphamide or different other chemotherapy drug. We also use a lot of what we call the proteasome inhibitors, mainly Velcade or bortezomib. Again, for the Cybordy regimen that many of you might have received, it's the Bort part of it. So Cybordy, which is the Velcade. And we have its cousins, Ninlaro or ixazomib, that is a by-mouth version. And we also have carfilzomib, who is another infusion version, or Kyprolis. We also have immunomodulators, which are also very good drugs that were first used in the 60s for pregnant women having nausea, but recently we've been using it. It was kind of found randomly that they have action against cancer, and especially multiple myeloma cells. So we now develop drugs that are easier to tolerate than the first one that came on the market, which was thalidomide, that we still use sometimes, but we use much more of the newer drugs like Revlimid or lenalidomide or Pomalyst or pomalidomide. And we also more recently have already some immune therapy, and we'll talk about it later, how they work. But we have the monoclonal antibodies such as daratumumab and Darzalex, and also isatuximab or Sarclisa, which are already some forms of immunotherapy that we have access for most patients these days. So these drugs exist. I did not mention also the dexamethasone that, of course, many of you have taken in the past, because we always use it for multiple myeloma. So this is also another drug. So we're going to talk about the newer drugs and what's coming, really the newer medications. But one big area of development for multiple myeloma is also using the previously mentioned drugs, so the one we already have, and try to mix them together in a way to bring new regimens. One of the characteristics of multiple myeloma is that, unlike some other cancers where all the cancer cells are really the same, so one cell, we look at one cancer cell, we look at the next one, they're really similar and always have the same mutation, the same genes. In multiple myeloma, we know that there is a lot of different mutations or different cells, so they're not always the same. Meaning, if we can find a way to attack the cells with different drugs at the same time, then we can overcome resistance and get much more better result. So in the past, we were using some treatment like Velcade and dexamethasone, which is Veldex, or Revlimid and dexamethasone, which is Revdex regimen. And more, and I think for mostly every patient now, we're using triplets regimen. So instead of giving 2 drugs, we now use 3 drugs. So Cybody regimen is an example. We have cyclophosphamide, bortezomib, and also dexamethasone. And instead of using Revdex, we now use daratumumab Revdex, so triplets regimen. And there's also coming just this year, there was a new regimen that was approved. We're still waiting for funding to come for easy access for everyone, but there's newer therapies coming for patient relapse after a transplant, such as daratumumab, carfilzomib, and dexamethasone, which seems to give very good result in the clinical trials. So again, more and more combination, finding ways of giving the drugs together. The challenge is always to have the drugs that kind of work differently, so they fight the cells with different ways, and also they don't have added toxicity. Because one thing we want to make sure, if 2 drugs give very bad neuropathy or very hard, let's say, on hemoglobin, then maybe it's hard to put them together. But the more different the drugs are, then it's easy to combine them together without having too much toxicity and with added efficacy. And soon, I wrote soon on my slide, but actually some quadruplets, meaning 4 drugs together, are already in use and will be more and more used in the future, meaning better results also. So this is a big area of development. It's not meant to be the core of the presentation, but this is also something that's coming more and more. So what about newer therapies in multiple myeloma? So there are multiple newer agents that will completely change the landscape of treatment in multiple myeloma. And for many patients, they're not necessarily easily accessible now, but at least at Princess Margaret and in many bigger centers throughout Ontario, these agents are already available. So through clinical trials at Princess Margaret, and sometimes through compassionate access, most of the drugs I'm going to speak about today are already given here. And most of these use the immune system and makes it more effective to attack the myeloma cancer cells. One of the most important thing to find new ways to fight the cancer cells is finding a target. We were talking a little bit earlier about cyclophosphamide and standard chemotherapy. Basically, these are non-targeted approach where we just find a way to attack the cancer cells while also attacking some other cells. So cyclophosphamide is a very good example. Basically, when we give standard chemotherapy, one of the property of chemotherapy is that it attacks any very active cells in the human body. And we know for sure that cancer cells, they grow fast, they proliferate, they give birth to newer cancer cells. So basically they are very active. So what we find a way to give a drug that will find its way to any active cells. So that's why when people receive chemotherapy, they can lose their hair or have some nausea. We know that the hair grow very fast every week, every few months. We have to cut them because they grow. So that's why they often fall with chemotherapy. Same with the nausea. We know that every time we eat, then the food will go through the stomach through the esophagus, and it irritates and it needs to heal and needs to repair every time we eat. So basically, these are tissue that are very active to repair, so meaning the chemotherapy will attack them. So one way to find a new treatment for multiple myeloma is to find a way to really target the cells that we want in a more targeted approach. So ideally, the best target that we can hope for is a target that is found just on the cancer cells or the plasma cells or the myeloma cells and not found on any healthy cells. And right now and throughout this presentation, you're going to hear me a lot speaking about BCMA. BCMA is one of the best targets that we have currently for finding the multiple myeloma cells in the body with our drugs. So BCMA stands for B cell maturation antigen, and we know that plasma cells are very mature B cells. So basically, it is very much expressed on plasma cells, but even more on multiple myeloma cells in comparison to normal plasma cells. And it is minimally expressed on other blood cells and almost not expressed at all on other cells, meaning it's a very good target to deliver chemotherapy or any drug. So this is a complicated slide, and I don't want you to remember all of this information. Of course, this is just to show you what the different drugs that are investigated at Princess Margaret with a picture. The main one I'm going to speak about today are divided into 4 categories. The first one is called antibody-drug conjugate, or ADC. The second one is called bispecific T-cell engager, or BiTE. The third one is called CAR T-cells. And the last one is an immunomodulator, just like Revlimid or Pomalyst or thalidomide, and it's called CellMod. So we're just discussing a little bit about this one at the end. So once again, this is a slide that is a little bit overcomplicated probably, but it's just to show an antibody-drug conjugate and what it is. I'll explain to you a little bit more of what it is. Basically, the name antibody-drug conjugate kinds of tell us exactly what it is. It is an antibody that we couple with a drug. So basically, it's an antibody that will be linked to an anti-cancer drug or a poison to the cancer cells. So in our body, the antibodies will circulate all the time. And what they do is they will move in the bloodstream and try to find their target. So any antibody has a target. It can be cancer, but it can be a virus. It can be a bacteria or any cells they need to eliminate, really. So it will always circulate in the bloodstream and try to find its target. So the purpose of the antibody will be to find the target. In most of the case, it will be BCMA, to be able to attack the cancer cells and the bad cells that we want to get rid of. And the way this drug works is that it is linked to a drug. So basically, the antibody will move to the bloodstream, and attached to it will be an anti-cancer drug. So one of the good example, and the one we use the most commonly in multiple myeloma, is called belantamab mafodotin, or belamaf. So this is a drug that's accessible through compassionate access, and there is many trials of Princess Margaret that studied this one, and one of them is ongoing right now. So basically, the antibody part is the belantamab. So it is an antibody that, just like any other antibody, will move through the body looking for its target, which is BCMA. And BCMA is on the surface of the plasma cells, and especially the myeloma cells. So it will find the myeloma cells, and with it, it's attached to mafodotin. Really, you could say just like cyclophosphamide. It's an anti-cancer drug, a poison to the cancer cells. And when all these drugs move to the bloodstream, the chemotherapy is not very active. It doesn't hurt anything. But as soon as the antibody finds its target, the plasma cells, then the chemotherapy gets inside the cells and will destroy the plasma cells. So it's really a way of giving chemotherapy, but just strongly and locally to the really bad cells we want to get rid of. So the good side of the belantamab right now, we have used it mainly for patients that don't have more options, and we know that even if nothing else was really working anymore, it can work very well for a number of patients. It doesn't work for everyone, but when it does, it can work for a long time. And because of its really targeted approach and the fact that the chemotherapy just goes to the myeloma cells and not on other cells in the body, the good thing about belantamab is that it doesn't come with the usual bad side effect of the chemo, such as fatigue, nausea, diarrhea, sometimes hair loss, and all these things. So overall, patients feel very well while receiving this therapy. And it's usually given every 3 weeks, but maybe in the future, we'll find some other schedule and give it less frequently. Now, the downside of the belantamab, and the reason some patients sometimes wants to avoid it's that it's associated with a toxicity that sometimes scares patient, which is the change in vision or cornea change in the eyes of patient. So at first, when I discuss it with patient, many are scared by the fact that it could affect their eyes. And in reality, for many patients, it will have a small impact. But after using it very much at Princess Margaret, what we notice is that usually it can be asymptomatic, and just the eye doctor will document some changes without the patient even noticing. So we'll take a break to avoid anything happening. And for other patients, they don't get very bad vision. Most often than not, they will have a little bit of the blurry vision. We stop the drug, we hold it, we wait, and then we take a look, make another eye exam, because an eye exam has to be done before every dose to be careful and precautious about this drug. And when it resolves, the vision is back to normal, the eye looks good, the eye doctor is happy with what they see, then we resume the drug. And for some patients, they will receive it every 3 months instead of every 3 weeks, because there's a small diminution in their vision, they have to stop it. But the disease is still in remission, even if they've been taking it every 3 months. I've seen patients taking it every 6 months for 2 years, 2 years and a half. Disease still in remission. So maybe in the future, we'll find a way to give it less frequently than every 3 weeks, and we won't face that much of a problem with it. But overall, it's a drug that outside of this is very well tolerated. Patient can live with a good quality of life on that drug, and it works very well for many patients. The second part I want to discuss with you is the bispecific T-cell engager. So right now we're really hitting what we call the immunotherapy. And as I told you in the introduction, there's already some antibodies that we're using right now. So I want to take some time to explain to you what's different with these newer therapy and what's making it important for the development of those drugs. The drugs that we have right now that we can call immunotherapy are daratumumab and isatuximab, or Darzalex and Sarclisa. They are called monoclonal antibodies or naked antibodies. Basically, instead of being antibodies that are linked to chemotherapy, they're just antibodies. And this one, instead of targeting BCMA, they have another target that's CD38. And basically, it has the same purpose of finding the plasma cells that usually have CD38 on their surface. What they do is they will kind of coat the myeloma cells. So they will make like an envelope over the myeloma cells, and they will flag them and tell the immune system, please, this is a bad cells. I've identified it as being bad. Please get rid of it. And then the immune system will activate and kill the bad cells, the myeloma cells. Now, when we use the CD38 and when we use the naked antibodies, one thing we use a lot of the immune system. Many white cells will be involved, but the one thing we're not making participate is the T cells. We know for sure that the T cells are really a type of white blood cells that are cell killers. So they really have the function to kill other cells. And in our myeloma treatment, we wanted to fight the cancer cells, the plasma cells, but they don't get involved. So many cells will get involved, but not these ones. And we know for sure that they are good at fighting cancer. So basically, we need to find a way to activate the T cells and make them contribute to fight the cancer cells. So that is exactly what the bispecific antibodies or the BITE, they do. So on that image, I want you to look at the right part. There is a Y shape with an orange arm and a blue arm. So this is what an antibody looked like. So an antibody has this Y shape with two different arms, and we manufactured these antibodies to have two different arms. And if you look on the picture, the blue part is a BCMA arm. So basically a little bit like the lentamab or the others antibody we're doing, this arm will have the purpose of finding the myeloma cells in the body through BCMA. So it will be looking everywhere for BCMA, and when it finds it, it will link to it. Now the orange arm will have another protein. So instead of BCMA, it will look for cells that have what we call CD3. And CD3, what it is a marker or a protein on the surface of the T cells. So basically, it will bring the myeloma cells very close by to the T cells that are really cancer-killing white blood cells. So really the one cell that we want to participate in the immune system, we will bring it very close to the myeloma cells and allow to see that this is a bad cell. We want you to eliminate this one. And the bispecific antibody will also activate the T cell, making it effective. So it will kill the myeloma cells. So basically what we do, again, just to repeat it, making sure it's clear, we have two arms. One of them will be looking at the myeloma cells, the other one at the T cells. They will bring them in very close proximity and allowing the T cells to get rid of the myeloma cells. So that's how the bispecific T cell engager or the BiTEs, that's how they work. And of course, BCMA is a good target, but even at Princess Margaret, we have different targets already other than BCMA. So we could use in the future any other target and making the T cells act to kill really the myeloma cells within the body of the patient. The good side about the BiTEs, and we'll discuss a little bit the similar therapy right after that we call CAR-T, is that this one is very fast to obtain. Basically, it's a drug that's been already made. So as soon as we're ready to start it, now we see the M protein increasing. We want to avoid anything to happen. We want to start it very fast. This one is very fast. We can start it on a few days or at least a few weeks. We'll be able to start very fast usually. And at first it can come with some side effect like reaction, a little bit like some of you have received daratumumab, and it can first cause some reaction. So we have to give it slowly at the beginning to make sure there's no reaction. This one is a little bit different, but it can mainly cause some reaction when people receive it at first, like lower blood pressure, sometimes rigors and shivers. Many patients will not get anything, but some can get more important reactions. But basically, at first, we have to give it at a lower dose and more slowly and a little bit more frequently. But once we're started and patient tolerated well, then after that, patient will go on with that without any side effect usually. So it's very effective, and it's also very well tolerated outside of that early part where visits are more frequent. So the downsides is that there are some reactions after infusion, and especially now that we're studying those drugs, most of it are given on clinical trials. We are even more careful. So at first it means a lot of visit at Princess Margaret. So we have to give it inside the hospital for the first few days. And then the next week, most patients will come for another dose. But once we're started again, it will be until it doesn't work anymore. So we don't have a break. But it's usually very well tolerated. And after that, it's given every 3 to 4 weeks, depending which one we use. So a very intelligent way of making the T cells work, and a very effective therapy for patients that is usually very well tolerated. So a very interesting new drugs. Now coming to another part of the newer therapies that many of you might have heard of, the CAR T cells. So a very interesting field that's just, I would say, bringing revolution to many hematologic malignancies. So there's a lot of CAR Ts now for leukemia, for lymphoma, and more recently for multiple myeloma. So we're definitely using that more and more. A CAR T cells now is a little bit more complicated to explain, but basically, again, the T cells are cell killers, and they circulate in the bloodstream and they try to find their target. What they have on their surface to tell them what is their target is a receptor. So the receptor will tell them you're a T cells that has the purpose of fighting these kinds of cells. What is a CAR? It is what we call a chimeric antigen receptor. So basically, I could say that it means it's kind of human fabricated. We build it the way we want it to be. So we decide what receptor the T cell will have. So we decide what the T cell will be fighting. So it is a receptor that is made in a laboratory to target a protein on the tumor cells. And with the T cells now harboring this receptor, it will be looking for cancer cells as soon as it will enter the patient's body. So this is a picture to explain how CAR T cells are made. First, we have to build the CAR. We have to decide what receptor we want the T cells to have. So in multiple myeloma, most often than not, we want BCMA. So we want the T cells to target BCMA because, as we said earlier, BCMA is on the surface of all the plasma cells. So it is very effective at fighting the plasma cells. We want to insert the CAR inside the T cell. So once it's built, we usually use a virus to make it go on the T cells, and then we want to expand and get as many T cells that have the fighting cancer purpose inside the body. So we expand it, make it more and more, and then we reinfuse it to the patient, and hopefully it destroys all the myeloma cells. So we first need to collect the T cells. So when someone comes, the M protein is rising a little bit, we want to switch therapy, we want to do something about it, we first need to collect the patient's T cells. Now there's also some T cells that could come from other patients, or other individuals, meaning they're not the T cells of the patient, but for now, most of the CAR T cells come from the T cells of the patients themselves. Then we send the cells and we have them modified to really have the new target of the BCMA, and we expand the cells, meaning it takes a few weeks, often a month, before we collect the cells, send them to the lab, and have them sent back to us. In the meanwhile, we need to make sure that the disease is under control because it takes some time. So it's not unlikely for the patient to receive something else like radiation therapy or chemotherapy, anything, just to make sure that the disease is under control and it doesn't progress while we're waiting. And when the cells are ready, we make sure that we have enough, they're good to proceed, and then we give chemotherapy. Now, this chemotherapy has the purpose to fight myeloma, but it's not their main purpose. The purpose of the chemotherapy is really to clear the way and make sure that there's some room for the new T cells to really take their place. And then after that, we give back the T cells, the modified one, that are now have the purpose of attacking the cancer. And patient stays in hospital for a while for surveillance. So the good things about the CAR T, many of you might have received transplant through the course of their multiple myeloma, and CAR T shares a common thing with the transplant process is that we can give kind of a more intensive treatment, but with the possibility of a limited time treatment. And then after that, we hope for a long period of remission where we don't have to give anything. We just spoke about the bispecific antibody and about the belantamab. Usually we need to keep patients on that drug and we need to stay on it to make sure the disease does not come back and the M protein stays asleep. With the CAR T cells, we hope to give one big treatment and then the new T cells will just be circulating through the body and always making surveillance that no myeloma is growing. So basically we can give it and we can have an extended period of time without any treatment, which is often very welcome by patients after they've been on so many treatments for a few years. without a break. So this one gives a break. And unlike the transplant, for which we don't have a clear age cutoff, but it's unlikely for a patient, let's say at 78 years old, even if they're very healthy and very fit, to receive a transplant. We usually give transplant through 70, 72. If someone's very, very healthy, sometimes we can give it a little bit older, but this one does not really have an age cutoff, meaning we could use it for someone 78 if they're very healthy and fit. And maybe even older than that, really. And also, because we have some experience with patients with leukemias and lymphomas and also myelomas who have received it, at first there was some uncertainty around managing the new toxicities. It was so new. But right now we know more and more about how to treat those toxicities that can happen. Once again, we are mostly talking about reactions after patients receive it, like rigors and chills and lower blood pressure, sometimes shortness of breath. We now know the antidote for that and when to give it and how it works. So everyone at Princess Margaret and in most hospital where it's given, they know very well to manage those toxicities. And it's true for the doctors, but it's true for the nurses, for everyone involved with CAR T cells. Now the downsides, sometimes it's not the best idea for everyone. If the disease is progressing at a faster rate, and sometimes it would be better to go for a bite or for a drug that we can really start right away. And also it's a more intensive treatment, so patients need to stay in hospital for a while. Right now we're talking about 2 weeks in hospital, but it depends how it goes. But in the future it might change. And also, once it's given, if we have a side effects, we know very well how to manage it, but still we're stuck with the treatment being already given. Unlike the bite that we can stop and take a break, this one is given. We need to manage it. There's many good treatment that we can give if something arises, but still when it's given, it's already given and there's no turning back. So it's a bigger, more intensive versions. We hope that in the future, it's going to offer a possibility for cure. I'd say for now, it's hard to say that we really cure people with the CAR T cells. So it might be coming in the future. There's a new trial that just got published and with very encouraging result with a new CAR T. So this one might be one of the newer ones that we use. The last drug I want to speak about is what we call CellMod. Now, I don't want to get into details to how CellMod works. CellMod is a cancer pills, really in the family of Revlimid and Pomalyst. So it is in the family of drugs that we call immunomodulators. So it basically degrades protein even more than its predecessor. So it's quite simplistic to present it this way, but I think it's the easiest way to understand what it is. It is a much stronger versions of the others. So kind of a stronger Revlimid or stronger Pomalyst. So for those of you who've been taking these drugs, and most of you probably have, these drugs are very interesting because they are by mouth. And they usually are not so toxic, not so hard to get. So now it really depends on different patients, but they can definitely cause some infections, some diarrhea, sometimes some skin rash. But overall, they are not so hard to get, especially if we find the right dose for everyone. So CellMod is not unlike these others, and it's usually nice for patient to take this one because it's by mouth, and it can be given with dexamethasone or other chemotherapy. And what we know for sure that it works very well even when the tumor cells are resistant to Revlimid and Pomalyst. So we knew in the past that giving Pomalyst to someone who was progressing on Revlimid worked. Well, now we have another of these that seems to be working. It's still under trial, but it seems to be working very well for some patients, even some patients who have received some bispecific antibodies, some Pomalyst, and all of these therapies. We give CellMod, we have a tremendous fast response. So hopefully this takes some more place in the future within our treatment.
Dr. Larose, sorry, can I interrupt for just a moment? There's
Sure.
a really good question in the chat window that asks, are these treatments found to be more specific to the type of myeloma? So would it depend whether you got, the CAR T or the BITE or the CellMUD, depending on perhaps the type of myeloma that you're experiencing?
So meaning when you say type of myeloma, would you say like IgG, IgA, IgD, or mostly if you're high risk or not high risk? I'd say it's hard to answer these questions right now because basically most trials will just enroll every patient that is fit enough to go on these trials. So I don't think we have the data to say really which one is the best for an IgG myeloma or free light chain myeloma, or is it better for like a high risk disease. We'll get these data because people with high risk disease are also getting enrolled on most of these trials. So at some point we will look at those specific subgroups, but we're not there yet. I'd say for now, what really dictates which treatment is best for this patient is really what's the most interesting for someone. So someone could say, I really like to take a pill. I don't want to frequently go to Princess Margaret. With the BITE, they're very interesting, but you need to come even when it's at their best every 3 weeks for treatment. So if you come from Toronto, then it might be a good choice. But if you come from 3 hours from Toronto, then some patient will still like this one, but some will say, I'd rather take something that does not require as frequent visit as this one. So I'd say for now, we really would discuss with patient what is the side effect that the drug is giving. How often do you have to take it? Is it an infusion? Is it by mouth? And what's your preference? Which one would you prefer to take? Because we don't have a clear answer on which one is the most effective for which patient. So it really comes down to a matter of preference about the side effects that I've just explained.
Great, thank you very much.
So, Dr. Larose, it's Dave here. Just to follow up on that question, do you think maybe sometime in the future there may be some of these treatments that are observed to be effective with certain chromosomal abnormalities like translocation of 414 or 1114 maybe, but we're not there yet. But maybe sometime in the future.
Actually, I'd say we're not there yet for these therapies, but we are there for different therapies. We know for sure that the proteasome inhibitors or Velcade, carfilzomib, and also ixazomib or Ninlaro are very effective and important treatment for people with high-risk disease. So deletion 17p, translocation 414, these are treatment that works very well. So they're not newer therapies that are important, that I just presented, but there are therapies that we have access. And that's why many of you have high-risk disease who have maybe 1 or 2 transplants are having double maintenance. So we use Ninlaro maintenance often for these patients because we believe it's a very important part of their therapies. Now for translocation 1114 specifically, we know that there is a new drug that I did not discuss today that is called venetoclax that we use a lot for CLL. Unfortunately, it's not easily accessible right now, but we know that there's good activity for patients with translocation 1114. So I think this brings the table to let us hope that yes, we'll find which of these therapies are the most effective for which an abnormality. And speaking of 1114, we know also that a few of the newer drugs are not always so active. And one drug that is very, very active is just standard chemotherapy, like the transplant, an auto transplant, or cyclophosphamide, really, or these drugs are a very important part of treatment for these patients. So I believe in the future, we'll have data for which patient will benefit the most, and it might help in the future to choose which one of these therapies is the most appropriate for any given patient.
Thank you.
So I'm coming to what is the future. So we already discussed what part of the future was with all of these newer therapies that are now available at Princess Margaret. But there will definitely be room for even more improvement with all these new drugs coming. As I said in my introduction, we have many drugs, and we're still finding better ways of putting these drugs together through triplets and quadruplets and 3 drugs and 4 drugs together. So a lot of these drugs are now studied as single agent, just one drug to fight the myeloma. But as soon as we've proven that these drugs works, then we'll find a way to give it with other drugs, maybe, if they don't have added toxicity with the treatment. So, for example, we knew from the past that daratumumab was effective for patients with multiple myeloma. It works, but as a single agent, it doesn't work for every patient, really. So we now use daratumumab in combination with other drugs. So many of these drugs will maybe find their way through treatment earlier on. So not just as a single agent when there is no other treatment that are working, but really maybe in first-line therapy, when we first get diagnosed with myeloma, will we do in the future Cyborg-D and belantamab, or Cyborg-D and CELMoD, for example. And these are already under studies at Princess Margaret. We give belantamab with a booster for T cells. We give belantamab on different studies. They're basically the DREAM trials, DREAM 1, DREAM 2, DREAM 3. Now we do DREAM 5. So all of them studies belantamab either alone or in a combination with different agents. Same with CELMoD. Other thing, and we might hear a bit, you were referencing the American Society of Hematology meeting, and I hope we're going to hear something about new CAR Ts, because every company is trying to make the best one, and ideally the most effective one, and also the one that has the less possible amount of toxicity. And I think we're improving in this way also. And in the future, I believe we might find different targets. So right now we're targeting a lot of the BCMA, but as I told you when we spoke of the BiTEs, we have a BiTE at Princess Margaret that targets another protein that we call FCHR5. So maybe in the future, as I told you, with why we're using 3 drugs and 4 drugs together, it's that the myeloma cells are not always the same, and they can be a little bit different from one another. So if in the future we find a way to really give a therapy that targets BCMA, but also give a therapy that targets some other protein, maybe we'll get rid of all the myeloma cells, because maybe the reason why we don't cure completely, it's that most of the cells, they have BCMA at their surface, but a very small amount, but some of them don't. What if they have another target and we give the 2 drugs together, let's say a BiTE that targets something, a CAR T that targets something else, then maybe we'll get a very extended remission and hopefully cure at some point. Also, we know that the more the patient receives chemotherapy, then the T cells, they become a little bit more tired, because the chemotherapy is hard on the blood counts, as you know. So maybe if we bring the CAR T a little bit sooner in treatment, the T cells are going to be even stronger and more effective at fighting the myeloma. So that's also an area of interest. And I think it's open right now for enrollment, and it just opened at Princess Margaret, where we study CAR T in first line. So instead of receiving chemotherapy, we will and then just maintenance chemotherapy, patient will receive CAR T when they first get diagnosed. So this will be for patients that are not eligible to transplant, because we know transplant is so important part of therapy for some patients. So we don't want to get away from it just as of right now, but we'll try to bring the CAR T sooner and sooner.
Dr. Larose,
yeah.
Dr. Larose, there are a couple of questions in the chat that it might be good to look at right now.
Sure.
One is regarding toxicity. And the first question is, CAR T cells, have there been improvements in patient tolerance regarding the side effects of cytokine release syndrome?
Yeah, so all of them are a little bit different. So I'd say we might get newer CAR Ts with different side effects. I'd say the area where we improved the most is an aging cytokine release syndrome. not sure the new ones will bring less cytokine release syndrome, but it might be the case. Now, the new CAR T that will probably be hitting the market, because we know that we have Tcell that's already approved by FDA for multiple myeloma. There's a new one that comes from the trial that we call CARTITUDE-1 that just came out, and it's going to be discussed once again at ASH. We know that this one has the particularity of being a little bit stronger at attaching to BCMA, and we hope this will make it more effective, and it looks like it might be more effective. And this is the one we're going to study at Princess Margaret with newer diagnosis patient. But CRS syndrome, for those of you who are not familiar with it, is when the pressure drops. Patients have rigors, patients have chills. It's still happening, but most of it really for the CARTITUDE trial is what we call grade 1. So sometimes we just give Tylenol and there's nothing we have to do to manage it. And it's just a small amount of chills. So it doesn't seem to be a lot of grade 3 toxicity, meaning more severe reaction, at least for CARTITUDE, the product. Yeah.
So the other related question, will the multi-agent treatments increase lifespan, and will the multi-agent combo reduce access to future treatments for relapse?
These are very good questions. The first question, I'd say hopefully. I hope it's going to cure patients in the future, and I hope it can extend the length of response for many and the length of remission. For the second part, it's an interesting question, because we've been asking ourselves these questions for many different diseases also in the futures, for multiple myeloma, but also other very indolent disease like chronic lymphocytic leukemia. And what we learned so far is it's usually better to give all the drugs together at first, and having the disease exposed to many drugs rather than waiting and giving all of them together, just one after another. And especially for myeloma, where the cells are different from one another, I think it's good that we give all the treatment together. And one thing that can happen if we don't do that and we give a treatment, we wait for a while, and when it doesn't work anymore, we give the next one, is sometimes you can get sick in between. The disease progresses, there's a new bone fractures, the kidneys are not good anymore, it's hard to give the next treatment. So what we learned from the past is that some patients, we hope to bring them to the next treatment, but they don't make it to the next one because they're too sick. So basically, that's why we prefer to give all the treatment together when we can. And I think the most important thing is you get all of these drugs at some point. Now, what's sometimes limiting us from doing that is we cannot always give all those drugs together, because we have to make sure that they're easily taken by patient and they don't have added toxicity, as I said earlier. Because if you give 2 drugs that share the same toxicity, it might be too much. And as an introduction, I told you that one of the things we're looking forward is for patients to enjoy life. So we want patients to be alive, we want patients to live as long as possible, but we want them to enjoy life and being able to do everything that they want to do. So this is very important that we also look at the quality of life while being on therapy. So we need to make sure that we can combine these drugs, allowing patients to live a good life with it.
Yeah, no, thank you. There's actually one other question that sort of picks up on this, and I know you're wrapping up, but maybe we should go for this last question as well.
Yeah, sure.
It's for the first timer. Should the patient start conventional? Should the patient start the conventional way, or would it be better to explore immunotherapy treatment from the start?
So we cannot really start with immunotherapy from the start, and one of the reasons is these drugs seems very promising. As I shown you, they work for many patients where nothing else is working anymore. So I think they can bring maybe many months or even many years to patients that did not have access to these a few months ago or a few years ago. But the thing is, we know for sure that an auto transplant, some of you might be an example of patients being alive without any need for other treatment 20 years after. Now, this is not the case for everyone, of course, but we know that these treatments are working. So the way we usually do clinical trials is that we look for these drugs for patients who don't have many more options, and we look at these and look if they're working. And if they are, then we will find a way to study them on trials sooner and see if they improve our first-line treatment. But right now, I would not be able to tell you, are CAR Ts better than our usual treatment, that is a transplant at first? I don't think anyone can say that. And that's why under clinical trial, we'll be starting it at Princess Margaret to study chemotherapy versus CAR T for first comer. But this is for patients who don't have access to transplant at first. So if patients are willing to participate in clinical trials and look for that, it's very interesting to do so, because in the future, it might mean that if we find out that CAR Ts are better, it's going to be CAR Ts for everyone. But right now, we know for sure that we have many therapies, and the one I spoke to you about in introductions are working well. So we always need more. But if I spoke about 10 years ago, the survival for myeloma patients was nowhere near as it is today. So these drugs are working. So before we abandon them for newer ones, we have to prove that the newer ones are actually better. And we don't have that data yet.
Yeah, no, these are great questions. And maybe you should wrap up. And I think there'll be some more coming like these.
Yeah, so I was almost finished. I'm very happy to answer question. But what I wanted to give to you as a conclusion is that I think the future is very bright for treatment of multiple myeloma, and we had many new treatments coming over the last few years, and this includes pomalidomide is not so old, Darzalex or daratumumab or Sarclisa and isatuximab are not so old as well. But I don't think there was ever a time with so many promising drugs at the same time coming on the market. So I think it makes us hope that these drugs will find their way and bring that survival and lifespan and quality of life for patients to new levels, and really even much more than what we can do right now. And with that, I'm very happy to answer any remaining questions.
Dr. Larose, may I?
I was,
go ahead.
I was just going to say, there was one more question.
Yep, go ahead.
That came in through the chat. There was just a question about approximate timeframes when some of these drugs might be available to patients after clinical trials. So if you have sort of an idea of a kind of a ballpark of that sort of timeframe.
Yeah. So this is very hard to answer, as we always don't know about the funding mainly. Right. I can say that among the drugs I already spoke about, belantamab or the antibody drug conjugate is already available, this one through compassionate access. So the oncologists, they might not all be aware. They need to file some paper with the company, but the company basically pays for it. They just need to have the eye exam done every time. So there's some things that comes with it. Some doctors might be a little bit less familiar with following patients on these drugs, but most oncologists will be in the very near future. So this one is available as of right now. For CAR T, it's probably coming quite soon. It's hard to say because it's already available in the US with FDA approved Tcell a few months ago. So it's coming, but it's very hard for me to say when it's going to hit the market, really. And often the drugs will be approved, and what we're always waiting for is for the funding to happen and not just the drug to be approved. They're not necessarily proven in clinical trials. You know how we do clinical trials? What we like to do is given one treatment to 1,000 patients, and another treatment, let's say a placebo, or another treatment to 1,000 patients. And most often patients are not always aware of what they receive, and we find that there's a difference, and one is better than the others. Natural treatments, they might be working well, they might have good effect, but the thing is, we don't necessarily have any proof of them working. And if I speak specifically of vitamin C, I know it was a big thing maybe 1 or 2 years ago. People, what they were saying about vitamin C is not necessarily that it fights cancer, but it makes chemotherapy easier for patients to receive. So a lot of people were saying, I got vitamin C and my body felt stronger. I was able to receive my treatment easier. Now, the one thing that's missing, and I think we should probably do a trial at some point, is a trial that proves that yes, 500 patients receive vitamin C, 500 they did not receive it, and chemotherapy was easier for them who received it. And in the end, everyone had the same life expectancy or same results. Because one thing that I would be afraid of is that if vitamin C makes the chemotherapy easier, is it because it makes it less effective? So before we start to give it to patients, I think we first have to prove that it's working, and second, we have to prove that it's not harming patient and preventing their treatment from acting. So I say, usually what I tell patients is that I definitely don't disagree with any of them taking natural products if they feel like it's working, because anything that could help, really, I think we're always welcome for those. The only thing is we have to make sure they don't interfere with the treatment, the chemotherapy drugs or any drugs, and they don't cause added toxicity. We don't have we don't have much more science behind them.
Just a quick follow-up to that. I, speaking personally now, I thought that I had been told by my hematologist at one time that I should not take vitamin C with certain types of chemo.
Yeah, you're right. Yeah, you're right. Sometimes it can interfere with absorption. So that's why I usually don't have any problem with patients taking natural product when they're not on treatment, when they're receiving treatment. And I'm not the best one to know if it interferes with the chemotherapy or any treatment you're on. So usually what I will make sure is with our pharmacist at Princess Margaret, what are you taking? Can it have some interaction? And our pharmacists are very good at looking at that. So any product you might take, I don't see any problem as long as it doesn't cause problem with the treatment you're receiving, either making it less effective or causing you more harm or more side effects.
Thanks. So there's another question here which picks up directly on some of the treatments you were presenting. In the event of a relapse post-transplant, am I correct in assuming that the patient does not have to go for a secondary transplant given the efficacy of these newer class of drugs? I think this is a common question that's coming up, and I'd be great to hear your answer.
Yeah, so the short answer would be no, it will not necessarily replace the second transplant. Now, it really depends on every patient. Because basically, if you got a transplant for multiple myeloma, a young patient got a transplant, get 10 years out of it without any treatment going on. We know for sure that transplant is not an easy treatment. We know it's hard, but usually we can expect a transplant, if it gave many years at first, to give many years once again without any treatment. So we usually consider doing a second transplant when patients got a very long amount of time with the first one, because we expect the second one to be another long remission. When we start these newer therapies, most often than not, patient will stay on it for a while. So for many patients, it will be important to them if they can get a treatment that will once again cause their disease to be in remission for 4 or 5 years. If the first one was 10 years, one can hope it's going to be 8 years, the second one. It's not always like that. So I don't think it will replace it. And also, another transplant sometimes is the opportunity to get another treatment. Basically, all these lines are going to be there at some point. They're going to be still available in the future. But another transplant, we usually do it after the first one, or we never end up doing it later on if we decided to move on and start usual treatment. So sometimes it's just like an added line of therapy, one more that patient will have access to. So for some patients, the answer might be yes. If you got, let's say, 2 years out of it, and we said it was very hard, maybe we don't feel like it's enough to get another 2 years or 1.5 years, and we have so many new treatments that are good that maybe we want to skip it and get to those newer therapies first. So for many patients, it might mean, yes, we're not going to do a transplant because we have many new things. But I wouldn't say that it's for everyone, that we will never do another transplant. Yeah.
Can you hear me, doctor?
Yeah, I can hear you.
Okay, my name is Jerry Parrott. I live in Oakville. I'm being treated by Dr. Reese at Princess Margaret. And I'm 76 years old, and I've had multiple myeloma for 13 years. And I have my myeloma is T414, and I guess I'm an outlier that I've lived this long with that subset. So I have a two-part question. My first part is I am currently on Revlimid and have been for the last 8 years with all of the side effects that people talk about. So my first part of the question is, all of the bites and T cells and immunotherapy and everything, is it all available to patients with the subsets, i.e. the 414 that I have?
So every different trial will have their enrollment criteria, their inclusion criteria, but I'd say most of them will include every patient. So if patient is healthy, some of them could say we're looking specifically at translocation 414. Some of them might say we're not looking at it, but I don't recall any trial recently that said we're not looking. Usually they want to look at it because it's one translocation that's really important that we find better treatment. So almost every trial will include patient with that specific anomaly or deletion 17p. And just to follow up on your first statement, I'd say it's true that people with translocation 414 or high-risk disease tend to have a shorter remission, but you're the perfect example that it's not always true. And there's a lot of different disease among those translocation. In the future, we'll need to further clarify, because we know for sure that many patients which we deemed are high risk are in the end not high risk. And in your case, having had the disease for 13 years, the length of remission now tells us that this is not a high risk disease. So even if we found that 13 years ago, it doesn't mean much right now, as time told us otherwise, really.
Okay, the second part of my question, if I decided, because of all of the issues with the Revlimid, that I wanted to get off the Revlimid and not get any kind of medication, and I guess at some point in time would relapse, would I then would I then qualify for bites, T cells, et cetera, et cetera?
So it really depends. I don't know, of course, all the details. Some of them, we have always ongoing trials. Some of them will ask for patient to have received X number of line of treatment before. Many will ask, because we know we have good drugs that are already working, like proteasome inhibitors, immunomodulators, and Darzalex or daratumumab. So most trial right now will ask for patients to have received a monoclonal antibody before. Some of them could not. So trials, they come and go. Some could say we can put every patient on it, and we have multiple trials all the time. So some could allow you to go on. Some could say we need patients to have failed these therapies before. So it really depends on which trial.
Okay, but there's no, the fact that I'm a T414 is not going to automatically exclude me from any of these new therapies.
It almost never does.
Okay.
Yeah.
Thank you, doctor, for your help. I appreciate that.
You're welcome.
Dr. Larose, I have two very quick questions.
Sure.
You caught my attention with the study or the treatment that requires eye examinations. Is that done through your own optometrist, or is that through the PMH?
So at PMH, and this is, I'm at PMH right now, and I'm going to go back to practice in Quebec City soon. And that's going to be one of the challenge that I need to work on when we go back, because basically as hematologists, patients on that drug are not very hard to follow because they really do well outside of the eye toxicity. And I myself cannot be looking at the eyes and look if the cornea is well. I'm not trained to do that. So we basically need to have good eye doctors to agree to follow our patients. And here at Princess Margaret, it is done through the eye clinic in the building I'm in right now. You know, the Ontario Power Generation building. So really, our offices are there, and there's an eye clinic downstairs. And the eye doctors over there, they are very well trained, and they see our patients every 3 weeks. So right now, it's happening just next to Princess Margaret at this eye doctor clinic. But every oncologist and hematologist that want to start using these drugs will need a good eye doctor to, like, it's not hard for them to do so. They just need to get involved. It's not a hard thing for the eye doctors. They're well trained to do that.
Okay, I guess my other quick question on that as well as a follow-up. I'm like most people on the call, we're older and had cataract surgery. So if you've had cataract surgery on both eyes, would that negate you from being in that treatment?
I don't know why, but most of the patients that have had this drug had even cataract surgery while receiving it, really. So sometimes the vision gets blurry, and it's because of cataracts. We first think it's because of the drug. So cataracts are removed, patient starts back the drug. So it clearly is not a problem, and it might even help, because sometimes we get stuck with cataract causing some blurry vision, and we don't know if it really is the treatment causing it or not. So it's definitely not an exclusion criteria to receive it.
And last very quick question, not related to that treatment, but anybody that's on DARA, I'm sure will agree with me. Are we getting any closer to DARA treatment by sub-Q?
We're using it more on clinical trials. So I would not be able to tell you about funding, because really that's a funding issue. It's not because it's approved. We use it on trials right now. We use daratumumab along with BITE sometimes, and it's giving sub-Q for patients who have received it in the past. So I think it's going to be coming soon, but I would not be able to tell you the date for that.
Thank you.
Excuse me, I have a question, if I may. Typically, what is the lifespan of a clinical trial?
You mean how long can patient expect to? It really depends, because among all of these drugs that I presented, there are responders and non-responders. And it will depend if the trial is given for patients who have only this very last drug left, or if they have many other drugs left, and we try to do a trial earlier on, because sometimes we can do it. It's very hard to say, because if we use just the drug with the eye toxicity by themselves, about 30% of the patient that are refractory to everything, they will respond. But when patients respond and it works, it can work for a very long time. And most of the drugs are like that. CAR-Ts, most patients will respond, but some will get very, very deep response where we don't see the M protein at all. And even if we do a bone marrow biopsy, we cannot find any myeloma cells. So it will depend a lot on this. And I'd say if you respond to treatment, it's likely to last for quite a long time for all these drugs. Yeah.
So it could be many years that one could be on a clinical trial.
I would not say that we expect it to be many years, but it could definitely be for some patients. Like belantamab, I've seen patients. CAR-T, the average is not many years, but surely some patients do many years. Like transplant, we would not expect someone to have. We will not tell to any patients at first that we expect a 20 years remission, but yet some patients get 20 years. So the average for a transplant with the maintenance is maybe 5 years, but some will get unlucky and get 2, and some will get 10. So it's hard to say, because patients don't. And one challenge is to find which patient is going to respond well to which treatment. And that was a good question throughout my presentation, to say, do we know if some patient with that gene mutation will respond well to this one, and patients with this type of disease respond well to this treatment? I think at some point we might get there, and it might tell us, well, this patient, because of this, should receive this specific treatment. It will work for many years. Yeah.
Patrick, are you gonna, there's a couple more questions, I think, in the chat.
Yes, 2 more questions, Dr. Larose. Regarding CRISPR technology, is it used in myeloma? And is it used for CAR T treatment?
So CRISPR technology, we don't have it at Princess Margaret for myeloma yet. So just for patients who are not exactly aware of what CRISPR technology is, most often than not, it will be used to use T cells from other patients rather than the patient's T cells. And it's a way to build the CAR T, really, another way to manufacture it in a lab. It might be available for multiple myeloma, but we don't have it at Princess Margaret, at least not yet. And I'm not sure if there are some CAR Ts that are under development. I assume there are probably some CAR Ts under development in like very earlier phases and like in testing, and not really available through patients through like later phases of research. I don't remember the second part of your question. Sorry. Let me just.
Is it used in CAR T treatment? I think you answered.
It is used for the CAR T treatment. Definitely, we have a trial right now for lymphoma at Princess Margaret using it. So it is used. I just don't know for myeloma if we have it yet.
Good. Okay. And the next question has to do with minimal residual disease. And they talk in the US about trying to reach a goal of negative MRD. Can you explain more about this? And is it a goal in Canada? And maybe I'll add to that. Could you just clarify the relationship between MRD negative and CR, complete remission?
Yeah, so basically what MRD means minimal residual disease. So if we look at what a complete response is, we look at exactly no M spike, so no free light chains. The free light chains are normal. And this is at least a very good partial response, or VGPR. When we speak about the CR, we often don't look for it because we know how unfun it is for patients to have a bone marrow biopsy. And sometimes it doesn't really change what we're going to do anyway. But when we want to speak of a complete remission or complete response, we have to take a sample, a bone marrow biopsy, and looks for no plasma cells on the bone marrow biopsy, really. When we speak about MRD negativity, it means minimal residual disease. So instead of just looking at the bone marrow biopsy and making sure there is no plasma cells in there, we look with more precise tools, such as flow cytometry or PCR. So basically advanced lab technology that we use to make sure that 1 in a million cell is not a plasma cell. So the human eyes can see 1 in 100 cell, maybe if we count 100 cells, but we cannot really find a very just isolated cells by itself that is still there. So MRD can do that. We basically look all the cells in the bone marrow, it goes to a machine and it tells us there's no more plasma cells. So it's really, when you are MRD negative, it means there's really no myeloma left. With that being said, MRD negativity will usually not really change how we treat treatment, but we treat patient. But what it will tell us is how long of the remission we can expect. If MRD negativity is long, usually we would expect the remission to be longer. We would not necessarily do something else based on the fact that we know there are still some cells or no. So maybe in the future, it's going to be something we do. We assess for MRD, and it's positive, there is more maintenance. If it's negative, then no maintenance or less maintenance. What we know for sure is that MRD negativity tends to correlate with how long the remission is. And for some trial, it's very important because when we do research, we study treatments, but if we want to give them to patients, sometimes we have to prove to people who pay for the treatment that we're having a lot of benefits, like quality of life is better, patients live better with that drug, or they live longer, the remission is longer, and sometimes before they accept to pay for a drug, they need a good proof that it works very, very well. And it gives, but if we have to wait for life expectancy, you know that in multiple myeloma, sometimes patients lived for years and years, and this is a good thing. But meaning, before we know that this drug will make the disease last longer and the remission last longer, sometimes we have to wait for many years. So if we are to find a way to prove that this person is going to do better just by a testing like MRD negativity, it might brings all these drugs sooner, because we might be able to say to everyone who pays for the drug, well, it's going to make the people live longer, because we know more MRD negativity patients means they live longer. And we know that this drug makes more MRD negativity. So please, before we have to wait for many years to give our patients this treatment, look at this and please pay for it sooner. Don't know if this was clear. It's a little bit of a complicated subject, but it's a way of looking for how long we're going to get with the treatment, to not have to wait and see how long the patient does and estimate how long the patient might get with that treatment before.
Thank you. This has been fantastic. I'm going to pass it back to Dave for a few more words.
Well, actually, I had a
Or a
quick
question.
or a comment. Just to let you know, I'm on a BITE trial, and it's the one that you mentioned that is not directed towards BCMA, and I've had very little in the way of side effects, so I'm delighted about that. But the criteria for me to be included was that I had to have been exposed to a proteasome inhibitor, an immunomodulatory drug, and an anti-CD38 monoclonal antibody. So I think, Dr. Larose, as you were explaining, that's the case with many of the clinical trials. It's encouraging. You mentioned that there's a CAR T trial where it's being explored now for newly diagnosed patients. That's encouraging. But for most of us, again, you're not eligible until you've used some of the other standard therapies, and they are no longer working. Another quick question, or anything you might comment on, the CAR T, that sounds exciting. However, currently, like with the one that you mentioned, the Tcell, I believe the remission time is quite short, like a median remission of about a year. And it's very expensive. So when it comes to funding something like that, the cost effectiveness of that treatment versus other treatments, it's a challenge. Can I ask, what's your view of the future? Do you think we might get longer remission times and perhaps lower cost for these CAR T therapies?
Probably is. The more we do it, the costs are probably going to get down. I think they're already lower than what they used to be. For the recent CAR T, you're right that patients who have a remission with the Tcell usually get about a year. I think for patients who have a response, we can expect more than that. But since not everyone responds, and their lane of remission, some don't even get a remission with it, is less than a year. But patients who respond, we can expect some response to be a few patients, probably about a quarter of the patient. They made it over 1.5 years. And as we said, many patients have received everything else before, and most of the treatment they've received before might have given 3 months. So I think it can give still a long period of time, but of course we'd like it to be more than 1.5 years, and we have to find better ways. Now, the recent trial, CARTitude one that I was referring to, is at 12 months and 4 months of follow-up, the recent publication, and they have yet to reach the median PFS, meaning this, it's not a head-to-head trial, so we don't know for sure that the patients were the same, but it looks like we might get an average of more than a year. One can hope it's going to be 1.5 years or even more than that, and we always have to remind ourselves that many patients will do better than the median. Many will do less, but many will do more than that. For cost effective, usually if we can get a year of good health for someone, any treatment will be cost effective. If we were to prove that it's only giving 2 months more or 1 month more and it's costing 1 million, then people might not pay for it. But a year is still something that people are going to pay for if we can really prove that we get a year more than any other treatment we can do. I think it's a year is good, especially if you live quite a good life. And CAR T cells, some patients, once they're discharged, they live a really normal life without any treatment. So I think this is promising still, even if we can do better.
Okay, thank you.
I have a question.
Sure.
Maybe it's been answered. For the CAR T cell, is that like a procedure like the stem cell transplant? They draw your blood out, and can they use your stem cell transplant harvest that you have in the bank? Sorry if it's been answered.
No, it hasn't been answered yet. So this is a good question. So it is not exactly like a transplant, but yes, for now we have to collect the cells from the patient, but instead of collecting the stem cells, we collect the T cells. So it's not the same process. There is no Neupogen that people have to take before to make the stem cells go in the blood. It's a little bit different because basically we collect the T cells, a different type of cells. And I think this answers your second question, that we can't really use the stem cells that were collected before because that's not the same cells we're using. Instead of the stem cells, we're using the T cells. But the process feels a little bit similar. I'd say for many patients, the CAR T won't have any side effects or not much. It's not true for everyone. We know that some patients will get more significant or even severe side effects. But the transplant, we kind of always expect patients to feel something. Some go through it without any concern, but there's always some side effects. The hair loss, most people have a lower appetite. They feel a little bit tired, at least. For the CAR T, some people go through it. There's not much, but some will get sick as well. So I cannot say that we can say it's a very easy treatment. It is not. It is an intensive treatment, but much more easy for some patients and harder for some other patients.
Okay, thank you so much. I
You're
appreciate it.
welcome.